So we're having Professor Cathy Balding for the second interview again, focus on clinical governance in health service and healthcare organizational level. The first question is, from your observation and experience, has the introduction of clinical governance significantly improved the quality and safety of service provision in Australian healthcare organizations? So if the answer is yes, in what aspect that it has the greatest impact?
Yes.
If the answer is no, then why not?
Yes, yes. Well, the answer is yes and no.
So you didn't ask the question,
yes.
Right.
It depends on how it's implemented in each health service. And I see a broad range of implementation approaches and skills. Because if you see clinical governance as just another thing you have to do, you won't ever put the effort into implementing it in such a way that it really makes a difference. You'll just do the bare minimum and tick it off and say, oh, we've done that now. Hopefully that's enough for accreditation, you know. And unfortunately, there are still places with that attitude. It's changing. I certainly don't see as many of those places anywhere near as I would have even 5 years ago. But it still exists. I think where the CEO doesn't really understand the value or the purpose of clinical governance, it can still be a tick box exercise. So in those organisations, it really isn't having the impact it should. Where it is having the impact it should is obviously in the organisations who see the value of clinical governance, who see the value of clearly explaining what it is we're trying to achieve in terms of quality and safety, making sure that staff are very, very clear about their role in that, giving them the tools and support to enact that responsibility and calling them to account, right from point of care to the board, and using the various clinical governance systems that we have to support that and enable it. So not having clinical governance systems such as credentialing, for example, or risk management just as things we have to do, or even the things that do provide some value, but making sure they're part of a broader picture of what we're trying to achieve as an organisation for our patients. Otherwise, staff see clinical governance as just something else that they have to do on Tuesday afternoons. And in those organisations, some patients will be getting some value from that, but a lot of patients probably aren't. So, you know, what makes clinical governance value? When it's a means to an end rather than an end in itself.
So do you think that the accreditation process actually pushed the advancements of clinical governance and how it works in the health services?
Yes, yes. I think probably accreditation and the requirements of health departments have probably both contributed, particularly in Australia since 2013, when the National Safety and Quality Health Service Standards were implemented as mandatory standards. They were our first set of mandatory accreditation standards, and you know, we have a governance standard, we have a consumer participation standard, and the others are all clinical. So it was about saying clinical governance is about looking at our key risks, not harming our consumers, putting things in place to make sure that we're minimising harm and enabling our staff to play their role in that, and then making sure that everyone is accountable for their role. And so I think accreditation was very helpful because it spelled all that out in the national standards, in the governance standard, in the consumer participation standard, and then it applied those things to the key risk areas where consumers were being harmed or where there was greatest danger of consumers being harmed, such as management of blood, for example. So it provided a framework, and it also provided perhaps that non-negotiable element where even if the CEO perhaps wasn't that interested in clinical governance, they really didn't have any choice. Now, it's always nice if people do things voluntarily. Of course, that's your ideal situation. But in healthcare, where we've had a mindset of, oh, I'm sure the clinicians are out there doing a great job, we really did need that mandatory, non-negotiable push, I think, to help us to come to terms with the fact that, well, yes, they are out there doing a great job, but some days they're not, because they're only human, and you've got to have systems in place to support staff to do the best job they possibly can, and to catch them when they fall. And I think without that being a mandatory thing, a lot of health services, even today, would be saying, oh, no, I'm sure our clinicians are taking care of it, because it's a deeply held belief in healthcare.
I think will be interesting knowing now the reporting according to the accreditation requirements is still relying on the information provided by the organisation, the report actually written by the organisation themselves. So how the department ensure that the data information collected by the organisation and then analysed, put into the report are reliable and credible.
Yeah, well, that really comes down to good assessing. So when the accreditation assessors or surveyors or auditors, depending on which company they come from, go out to the health services, the skillful auditor will ask the right questions. They'll look for the source of the data. They'll have those conversations with the CEO. They'll look at how it's reported. They'll read the minutes of the board quality committee to see what sort of conversations happen. They'll follow it right through from source to reporting to conversation, and then they'll look at how does that board quality committee or other quality committees in the organisation respond to the data. Because reporting is an incredibly important part of clinical governance, of course, but only so far as it really does tell you something, and isn't just data based on fairly, questionable sources, which we sometimes see. We see a lot of dodgy data in healthcare. And B, what's the response to that? Because if we're just looking at data and not doing anything with it, it's kind of a waste of time. So the secret really is having very, very good accreditation assessors who understand that process and walk through it and don't take things at face value.
Well, thank you very much for that insight. My next question will be, can you please describe two of the most important elements that can maximize the benefits of clinical governance in safeguarding the quality and safety of service provision in health services?
Yeah. Well, it follows on nicely from your last question, because I think data is an enormous part of clinical governance, and maximising the impact of clinical governance really does start with knowing what's actually happening, which is why the search for valid and reliable data that give a meaningful picture of what's happening at point of care is an ongoing thing in healthcare. Our data systems are not great. There's not really enough dollars to go around to make the investment to make them as good as we need them, although that is certainly changing over time, and there are some health services that have got amazing data systems. But as a general rule, we're still struggling with that in healthcare to get really, really good data. But once you've got a data set that the managers, departmental managers, can really work with and really inform them about how things are going in their service, and that their managers can depend on to give an accurate picture of what's happening in their services, and that the executive and the board can have a meaningful conversation about. That's an absolute cornerstone of good clinical governance in a health service, and certainly across the whole health system. Without it, it's really, really difficult, because you're kind of guessing where to put your energy and your resources, and where the holes in your systems might be. So good data, well collected, well reported, with good conversation right across the organisation is, as I said, that's the cornerstone, and then responding to that appropriately. So to me, I would certainly start with that. And the other thing would be, which data is very, very helpful with, pointing the organisation all in the same direction, using clinical governance to help pull an organisation together and say, we are here for the consumer. That's why we're here. And as a board, our governance accountability says that what happens to the consumer at point of care is absolutely begins and ends with us. So to achieve consistently good, safe, quality care at point of care, we need the whole organisation working together. It's not enough just to have a few clinical governance systems that may make some difference for some consumers on some days and help some staff on some days do a better job. As a board, if that's our responsibility, we must lead the organisation to providing something great for every consumer every time. And so I think clinical governance is really, because of the governance element, it's really helping boards, rather than be a bit arm's length from all that, take a leadership role. And where I see good boards, that's exactly what they're doing. They're saying, okay, we know we can't just rely on the clinicians out there doing a great job. Even if they are, they're going to have good days and bad days, they're going to make mistakes. It's a complex system, things go wrong. We must lead the organisation. We must make it clear where we're going, what our expectations are, what we want for our consumers, and support the organisation to achieve it. So I think that understanding on the board's behalf that they govern for point of care is a very, very big change. But where boards embrace it, it's very, very powerful.
It's just something just popped me to my mind. If you don't mind, I want to ask you, now healthcare, one of the problems with healthcare is we don't have enough money to do what we really want to do and need to do.
Yes.
So I think sharing expertise and resources are really important between health services.
Sure.
So we recently submitted a funding application to NHMRC with 2 large health services in Victoria as our partners. Then we review the survey on patient satisfaction, survey on staff satisfaction, and also the risk management data collection system. We found there's huge discrepancy between the survey they conducted, the question they asked, the frequency they do it. So the question I'm asking is, how can we encourage health services to share expertise? And the app that we have can standardize what we do. Perhaps we will save cost as well. We save time.
Yeah. That's a tricky one. And perhaps we should have talked about it in the health system interview. Because I think traditionally, health services have been very self-contained. I think there's a big role for the Department of Health and Human Services in that, or Department of Health, however described in any jurisdiction. Because if they are clear about their overarching goals for what they want for the health system, and that's the important first point, then they can think about how to bring people together, how to draw on the expertise in various health services, how to pool it, how to share it, and how to use those limited resources in the best possible way to meet those goals. I think in the absence of a shared understanding of what we're all trying to achieve, you end up with people just doing their own thing based on their own environment, which is perfectly understandable. So to me, that's a really important role for any Department of Health, is to develop that clarity and then help people to pool and share their resources to achieve it. But in the absence of understanding and having that shared understanding, it's incredibly difficult to do.
So what you're saying is, without the support and direction from the system level, healthcare organisations cannot achieve the best.
No, well, generally, yes. I guess there are ways in which health services do pursue sharing, like the Health Roundtable, for example. So health services will get together, given the opportunity and the facilitation, they will get together and share, because generally speaking, they know that that's a really important part of knowing where they're up to and where they need to go, and then learning from others, how they've done better. So I think health services generally do understand that, but it's not well facilitated beyond things like sharing data at the Health Roundtable, or perhaps conferences, and there might be some other things that people attend. But from an all of systems point of view, we're not quite there yet. We're good at sharing some things, but in terms of pooling our resources to meet common goals, no, we've got a ways to go yet.
So apart from the system level support, I think the support from the board is very important. So what are the key challenges that facing the board in terms of implementing clinical governance in health services?
It's an interesting one, because some boards make it look easier than others, and I'm curious as to why that is. I think it certainly helps if your board chair deeply understands clinical governance. and your CEO deeply understands it, and they have a good working relationship. They would be critical factors, I think, because once you've got that, you can bring others along with you. You can develop your board. You can help them to better understand and play their role. But without those critical factors, I think it's really difficult. And sometimes I see not a partnership between executives and the board, but almost a competition. The board might start to ask difficult questions, or seemingly difficult questions, but perfectly reasonable questions about what's happening at point of care, that perhaps the data they're getting isn't satisfying them, that they really feel that they know what's going on, and that's perfectly legitimate for a board to do. And the CEO and the executive might react badly to that. Instead of saying, oh yes, I understand why you would want to know that, we'll go away and find out, they'll say, oh, you don't need to know that. That's operational, you need to stick with governance. And I think this is a very difficult line, that the governance operations line is a very difficult line to really grapple with. I think that is a big challenge in clinical governance implementation. How much does the board need to know? How much say does the board have in what should be happening at point of care? How do they enact their role if they don't have some say? It's really quite difficult, and I think we haven't nailed that yet, and I think that is a real challenge for boards in implementation. So that would be the first thing, that the relationship with the executive and their mutual kind of understanding of what they're trying to achieve. The second thing is that we're still in a mindset of, particularly with a lot of doctors, where why on earth would a board be interested in anything I'm doing? It's really got nothing to do with them. I think until that mindset changes and we understand that actually it's not about you, it's about the patient, and what we're trying to do is support you to provide the great care that you really want to provide. Until we have a shared understanding and universal understanding of that, I think implementation will be quite difficult, because and I'm singling out doctors, but because they are, so much rests with them in terms of quality of care. Every other health professional has an important role as well, but the doctors do make a big difference. Where they don't really get it, and the board isn't very good at explaining that, or the executive isn't very good at explaining that, implementation is hard, because you're not working together to a common end. You're almost setting the board and the clinicians up for conflict, and that doesn't help implementation in any way.
So in Victoria, who's actually playing the roles in supporting and educating the Board of Health Services?
It varies. The private sector obviously would have their own corporate approach. In the public sector, we have various board educational opportunities that come and go a little bit. It's probably been a bit patchy. There has been significant board training over the years, but depending on departmental priorities and funding imperatives, these things change all the time. It's a complex environment, So some boards seek their own training and development. The Institute of Company Directors, has a module on clinical governance, but I believe that we need a really consistent flow of orientation and training for boards, because getting their heads around this is not an easy thing, and yet we need them to have their heads around it.
Well, thank you very much for your time again and your insight, and I believe that our students or whoever can have access to the interview will get benefit greatly from you.
Thanks.
Thank you very much for your time.
My pleasure. Thank you.